Yes, sir. Perfect.
So we're going. Thank you. Hello, I'm audible?
Yes, doctor.
Okay. Good evening, everyone, and welcome to another day of Foundation for session in palliative medicine. So today our session will be on pain, and especially with special focus on methadone.
Sir, I think you are getting muted again and
Sorry, I'm facing some issue. Just
no.
give me a moment, please.
Sure, sir. And Dr. Arjun, by the way, our faculty has just informed that she might be a little bit late in joining. So maybe you can utilize, you and other
Yes,
learners
yes,
can
yes.
utilize the time for other healthy discussions, whatever from
Yes.
whichever topic you feel like. So just wanted to update that.
Definitely. Anyway, we have some we have some time for a discussion. So before the faculty joins, is there something particularly you want to have a discussion on, especially on the previous sessions you have attended? If there is anything you want to discuss, let's have a discussion. We have some time for discussion.
Palliative care. Indian Primer on Palliative Care by Pallium India. And there is another one, Introducing Palliative Care by Dr. Robert Waycross. And if you want to read more things, then get Oxford textbook of palliative medicine.
There's another question: what to use for breakthrough things when patient is on fentanyl patch or buprenorphine patch?
Yeah. So you can either use if you have injectable preparation, use injectable fentanyl, or but most of the time it is not available. So use morphine. Not you have to use short-acting morphine. So even though we call it as short-acting morphine, it has a duration of action of 4 to 6 hours. So usually we say it's about 4 hours. So the medications which we can use in breakthrough pain should be short-acting medications.
Can the conversion table from fentanyl patches to mild or moderate analgesics be circulated?
So just remember that 60 milligram of oral morphine is equivalent to 25 microgram of transdermal fentanyl patch. So the whatever be the strength, 25 microgram, 12.5 microgram, or 50 microgram, it indicates that that much amount of fentanyl is liberated into the systemic circulation every hour. Okay. So 60 milligram of oral morphine is equal to 25 microgram fentanyl patch. That is 25 microgram per hour fentanyl patch. So 120 milligram of oral morphine would be roughly equivalent to 50 microgram of fentanyl patch. So if you remember the 60 milligram oral morphine is equal to 25 microgram fentanyl patch, then you can calculate the other doses. Before giving morphine, we should roll out red flag signs. Can you please explain about it? Surgeon, any idea what is this?
No, sir. I'm confused. Dr. Pooja, can you please explain?
Yeah.
Sir, actually, in one of the article, it was written that before starting morphine, rule out red flag signs. So that has been written in one of the article which you have circulated, sir.
Sir, can I explain this?
Yeah,
The
yeah.
red flag, sir, red flag sign of morphine is that patient might not be in hypotension. If patient in hypotension, sir, morphine not to be given.
So I do not think there is such red flag signs as such, but if
Sir,
there is some patient with severe respiratory, suppose the
distress
respiratory
and
rate is less
hypotension.
than 6 or 7, that would be a red flag sign. You should
Yes,
not
sir.
give morphine in such cases because that will produce more problems. And maybe comparatively, red flag sign might be a patient with severe
Hypotension, sir.
renal disease. But even then, for who works in India, where most of them have only access to morphine, a small dose can be used. That is not, again, not a contraindication. I think only the absolute red flag sign would be the respiratory rate less than 7.
It is written like this: cancer pain emergencies and or red flags, bone fracture or impending fracture of weight-bearing bone, epidural metastasis, leptomeningeal metastasis, infection, obstructed or perforated viscous, and recurrence of the disease. So this is there in a red flag sign, sir.
Okay, so they might be indicating that this by giving this might mask something. If you give morphine, and I don't know what does that mean, but still.
Again, sir, patient with ruptured sir, intestine perforation, sir, there will be hypotension. Sir, in emergency medicine, sir, morphine avoided in first hypotension and second respiratory distress. Even, sir, low dose can't be preferred in these cases, sir.
No, not respiratory distress. It is less respiratory rate less than 7.
Maybe, sir, but we can't prefer, sir.
Thank you, sir. Thank you, ma'am.
Dr. Sunil?
Yeah.
Sir, actually, I got a message just right now from Dr. Gayatri that she's facing more delay than expected. So she was asking if it is possible for us to like give a short break and then rejoin at 6.
Yeah, I think that if that is the case, that should be, yeah, I think we do not have a choice as of now. So can I request all the participants to break for now and rejoin at 6 o'clock using the same link?
Sir, have you uploaded the last, I mean, last session's video on the YouTube?
Not yet, not yet, Dr. Vadera, because there is the conversion of the link is still going on. So I think we'll be uploading it by tomorrow only.
Okay, thank you. And even slides are not uploaded, no?
Yes, yes. Because as I already informed, there might be a slight delay in some cases, like 2 to 3 days time.
Right, right. Okay,
Just keep looking out for our messages in the WhatsApp group, because once we have uploaded all the contents, the coordinator will be updating in the group that the contents have been uploaded. So till that time, it might not be available. Once we give the intimation that the contents have been uploaded, you can definitely get the access.
Sure. Thank you.
Dr. Etisha, actually, we don't have a case presentation for the methadone topic. Otherwise, we would have definitely have started off with that. So what we are presently going to do is we are keeping the meeting open. So those who want to take a break can definitely go and maybe grab a cup of coffee or tea, take a small break, and then rejoin at 6, because we will be expecting our faculty also by then. Sangeet, we can just pause the recording and we will resume it at 6 once.
The Institute of Oncology and Regional Cancer Center, Hyderabad. She is originally an anesthetist and also founder member and currently the executive secretary of the NGO Pain Relief and Palliative Care Society in Hyderabad. She also contributed to the development of curriculum for the IAPC, or the Indian Association of Palliative Care, and also been involved in opioid availability activities through IAPC and Pain and Palliative Care Society, Calicut. She has participated in the initial planning of palliative care in the National Cancer Care Program for Sri Lanka, Indonesia, and Philippines. She is also a director of the Palliative Care Initiative in Southeast Asia of Two World Cancers Collaboration, the Canadian branch of International Network for Cancer Treatment and Research. She joined the IAHPC Board of Directors in 2010 and is currently serving a second term. She is particularly interested in advocacy activities related to improving access to opioid medications and standardization of training programs in developing countries. So as soon as ma'am joins, we can hand over her to start the session.
Dr. Ma'am has joined.
Hello, ma'am. Good evening and welcome to the session.
And thank you very much, Dr. Arjun. And first of all, I really want to place on record my sincere apology to Pallium India and to all the participants for the delay, which was totally unavoidable from my end, and really apology. So it's a pleasure joining all of you. And I'll start by sharing screen from my end, if you permit me. Can you see the slide, Arjun? Yeah, thank you. So today, what I thought.
Yes, ma'am, you are audible.
Wonderful. Yeah. So thank you, Dr. Arjun. I'll look at some practical aspects of methadone. When Sunil asked me to do methadone, I'm sure for many of you, you're still getting familiar with morphine. So here I'm discussing about something more as a level 2 kind of opioid, methadone. So we'll keep it very simple and see how best we can, some take home we can take from about understanding methadone. I want to start with saying that methadone, whatever we discussed today, is just the basics. Those who are interested, I really recommend that you have to undergo more proper clinical training before you can start using methadone. That which applies to all opioids, but more so with methadone, because we'll discuss why I'm saying so much about methadone as which requires special training. So some important aspects of methadone from historical point of view. Methadone was introduced as a strong opioid. It is a strong opioid and step 3 of the analgesic ladder. You must have learned by now 3-step analgesic ladder, step 1, step 2, step 3. Methadone belongs to step 3 along with morphine and fentanyl. Way back, it was introduced in 1940 as analgesics, but for various reasons, because of some incidents of sudden death and some serious events, it disappeared from the market and came back again in 1980s, because then there was a better understanding of its pharmacokinetics and pharmacodynamics. And it came back, re-emergence in 1980s. And 2017, the World Health Organization included methadone as one of the analgesics in essential drug list in the latest edition. So there's a comeback of methadone as a very important step 3 opioid analgesics for pain relief. In India, early years, 2012, it was introduced as a substitution therapy for pain dependence treatment or opioid dependence treatment. In most of these drug rehab centers, they were using methadone as a substitution therapy. And it was only in 2014 that it became available. It was allowed to be used for pain management. And in 2015, with I don't know whether you had this session around opioid availability, Government of India amended the regulation around opioid availability, and methadone was also included as a essential narcotic drug. The list of narcotic which came under NDPS Act 2015, along with morphine, fentanyl, methadone, three drugs which came under essential narcotic drug list. And for all the three, methadone, fentanyl, morphine, the common law applied, regulation applied. So if you have questions around that, we'll take more questions around what it means. If you have not got a class around for related to that. How many of you have used methadone in your practice? Just as a curiosity, I just want to see if we can put it on a chat. Has anyone of you used methadone in your practice? I know that Dr. Arjun is using it because he works in Pallium India and they have it. Anyone else who has used methadone? I see no, most of the time, most people are saying no. Yes, no. I will not be surprised, which is absolutely fine, that most of you don't have experience with. I see a lot of no's coming up. Yes, I'm not surprised. It's absolutely fine because we are still struggling to procure morphine, and most of us as a doctors and nurses getting familiar with use of morphine. So methadone is a second level thing. And as Dr. Deepak Shrestha says, it's not even available. Yes, many in your country also it is not available. In India, it's only recent event, and Nepal and other countries, it is simply not available. So I can totally understand. But it's very important that we understand methadone because it will come to your country soon. Because it's being used as a very important analgesic the world over. If you look at all the Western countries, they use methadone sometimes even as a first line. So it's important that we understand methadone a little more in detail. Look at this example, a 42-year-old man with a CA buccal mucosa. He has severe unresolved pain over the left side of the face, scalp, and neck. He's on oral morphine, 60 milligram Q4H, 120 milligram bedtime, and 60 milligram SOS. The patient is drowsy, but his pain is not better. So what kind of pain do you think he must be having? With this, if you just look at his picture with this kind of presentation, what is the source of pain? So much of pain he's complaining. What could be the source of his pain? If you can think of, look at his wound. He has a orocutaneous fistula, oral cancer, yes. So in what way it can cause pain? Infective, very good. Yes, cancer itself can cause pain. Nerve involvement, yes, as the cancer eats away the structure, the whole of nerve is eaten away and open nerve endings, and it can cause neuropathic pain, exposed nerves. Absolutely, I totally agree. Directly because of the wound, nociceptive, and neuropathic because of the nerve involvement. And infection, as many of you said, and also bone involvement. So if you just quickly, yes, absolutely, bone involvement and psychological pain, of course, we have to always remember that trigeminal nerves are involved. So if you see, it is not a very straightforward pain. It is a very complex, chronic, complex and neuropathic pain condition where multiple reasons are there. If you just look at this from a pathophysiology point of view, and he's on oral morphine and he's drowsy. So we can't really go up on morphine because he's not responding to morphine. So normally in these circumstances, what do you think? What do you do when we can't go up on morphine? Patient still has severe pain and you strongly suspect there's a neuropathic component to it. But what kind of analgesics then you'll think about? Do you add something to morphine based on your experience? What would you do now at this point of time? Will you add any other medicine? You can't go up on morphine because already, yes, NSAIDs we can add. There's a lot of inflammation. Nerve blocks may be helpful. Asra K says adjuvant drug. Can you think of any adjuvant drug which may be helpful for this patient? Yes, gabapentin, tricyclic antidepressants, pregabalin. Yes, typically classic way how we manage this kind of complex neuropathic pain is adding adjuvant medication like gabapentin or tricyclic antidepressants. And so that's how we normally manage. Sometimes steroid is helpful and NSAIDs. Yes, but can we think about an opioid which may be helpful in this situation? That's where the role of methadone comes. Now, if you look at methadone, it is an opioid analgesic, which means that it works on opioid receptors. So primarily, it has a R racemic mixture, R and S, and the R form works on U and delta agonist. It is a opioid receptor. It works on opioid receptor. But interestingly, methadone also has action on other receptors like NMDA receptor antagonist, serotonin and reuptake inhibitor, something like TCA-like action. So it has multiple actions. Not just opioid-like action, it has got many other actions. And that often works to our advantage when we are dealing with chronic complex pain condition. And that's the reason methadone is considered as one of the drug of choice when you're seeing a patient with complex chronic non-cancer or cancer pain with both nociceptive neuropathic component to pain. So remember that because of its, even though it is an opioid with typical opioid action, it has got multiple other actions. Beautiful drug because it has got high opioid availability. 80% if you take orally, it gets absorbed, and even sublingually, it works. Very rapid onset of action, and peaking happens 2 to 4 hours after injection. But this is beautiful. What bothers us all the time, which makes us worried, is that it has a very long half-life. That is something you must remember. Even though it works quickly, peaking action happens immediately, half-life is quite long and unpredictable. So typically, it takes 5 to 7 days to stabilize. Remember that. Your take-home message should be methadone takes 5 to 7 days to stabilize. Suppose I start a patient on methadone, I should be acutely following this patient for at least 5 to 7 days before I say, yeah, this is the dose a patient needs. If you don't do that and rapidly increase initial few days and patient goes home after 3 days, the peaking will happen after a week and he'll be drowsy in his home and you won't even know. And it may be disastrous. So that is something we have to remember. It is metabolized in the liver. There is no active metabolite and safe in renal failure. So it's one of the drug of choice for patients with chronic kidney disease. Methadone is one of the safest drug to use. Remember that. Morphine has a lot of issues because it has active metabolite excreted in the kidney and it can cause accumulation. But methadone is quite safe in that way that it has no active metabolite and it is safe in renal failure. The other problem with methadone, I'm highlighting some of the problems. Because of its adverse effect, like it has an action on QT prolongation and serotonin syndrome. So because of its action on S-methadone, remember I told you it works on serotonin receptor and NMDA receptor antagonist. These are the problems which we see. Whereas working on opioid receptors, you see other opioid side effects like nausea, vomiting, constipation. But it is less common than other opioids. What you see with how much you see with morphine, it's not so bad as you see with morphine. But what worries me most here is that QT prolongation. So I'll leave the slides with you. You don't have to learn by heart, but there's a clear list of drugs where we can look at the drugs which are at high risk for QT prolongation, possible risk and conditional risk. So when you're using these drugs along with methadone, sometimes it can be harmful. So for example, if your patient is on ciprofloxacin and you're adding methadone, you may, it can be a problem. So remember that QT prolongation is when you take with methadone more chances. And also it's because why this something drugs like gluconazole or azithromycin, ciprofloxacin, it is enzyme inhibitor, cytochrome enzyme inhibitor. So an enhancer, sorry, sorry, I'm looking at conditional risk means it's not that a drug, it's in combination. It can how it conditionally it alters the enzyme and the metabolism. So it varies. So that's the reason it is called as conditional. So the question often asked is, shall we take ECG for all patients who are on methadone? Normally, it all depends on what is the goal of care of your patient. If the patient's goal of care is comfort care, admitted in hospice for end of life care, then I will not really go into all of this. I'm just looking at pain control. But if the patient is in your hospital undergoing chemotherapy or radiation, and your goal of care is you're still looking at a possible cure of the patient or prolonging the life, and I'm adding methadone for some reason, I want to really rule out all of these things, and I'll look at the predictability of QT prolongation in these patients. So whether to go for routine ECG and other problems depends on what is your goal of care. So definitely, they say please take ECG as a baseline if you see any of these problems when you're starting a patient on methadone. Positive risk factors, like if suppose a patient is on electrolyte imbalance or some medications which can increase the probability of increased level of methadone in the blood because of enzyme inhibition, and so there's a chance of increased methadone level in the blood and more QT prolongation, or if there's already pre-existing prolonged QT interval. So when you take a ECG, you can make out, so how much is the normal QT interval, and suppose there's a prior history of arrhythmias. General recommendation, they say, do not use methadone if the QT is already more than 500 milliseconds, and moderate risk between 450 to 500. This just, you don't have to worry too much about it right now. Just remember that methadone can cause QT prolongation, and there are instances of sudden death. So you have to be mindful of that when you're using methadone, and especially when too many other medications are being used along with methadone, and patient is already having dehydration, electrolyte imbalance, that these are all risk factors. So like I said, some medications can increase methadone level and increase the risk. Some medications can decrease methadone level, and it can, then you need to have more methadone for pain relief. So both ways we have to see. So that's the reason when you're using methadone, it's very important that you also undergo some real actual clinical training before you become confident about use of methadone. I'll just leave this. Sorry. We have two different formulations of methadone. We don't have injectable formulation. We have syrup methadone, which is available as a 150 ml bottle, and each ml contains 5 milligrams. And it's quite cheap, actually. Just like morphine, methadone is quite cheap. So that's the reason probably the pharmaceutical company also not very interested to sell methadone, because it's so cheap, not much of a profit margin. You also have tablet in the form of tablet. One tablet is 5 milligrams. And for both, you need licenses, just like morphine, to procure it. Different routes of administration: oral, sublingual, buccal. Suppose end-of-life care patient, you want to use methadone and patient can't swallow, you can just leave it in the buccal area. It can still be absorbed, or you can give via rectal area. So some dosing consideration quickly, this next few slides. Now, I want to share this paper. I request the organizers to please share this white paper, expert consensus around the use of methadone. It's a very excellent paper. Those who are really interested to go more detail into use of methadone, this is a nice guideline where they very clearly describe how to use methadone in terms of dosing and other things. And this is based on a lot of experts coming together, and they developed the guideline. So what they say is that patient selection, they describe which patients have been ideal to use methadone. Moderate to severe pain, of course, step 3 of the analgesics. So they say as a second line opioid choice. Some centers even the use as first line. But for all severe degree pain, we can think about methadone. Pain refractory to other opioids, like complex neuropathic pain condition. Patients with renal failure, severe end-stage renal condition, methadone is a safer bet. Suppose a patient developed tolerance to morphine. Some of your patients may develop tolerance to morphine, and you need to go very high on dose, still it doesn't help, and That's the situation. Sometimes what we call it as opioid rotation. We rotate from one strong opioid to another strong opioid, and that's the time when we use methadone. And suppose a patient has very poor, serious adverse effect with morphine. For example, a patient takes morphine and develops severe constipation and is just not liking it. Then sometimes we switch over to methadone. And suppose a patient has swallowing difficulty because we have liquid form, we can use methadone. These are the different way where we can think about use of methadone. And also need for long-acting opioid. Always remember, when you're using methadone, start small, go slow. That is my standard recommendation. Start small, go slow. We can start as small as, suppose, a very opioid naive patient, and the first time using methadone, you can just start by even small dose as 1 milligram or 2 milligram, single dose, or twice daily. Twice daily, 1 milligram. We can start like that. But start small, go slow. Increase by every 5 to 7 days. Remember, I told you prolong half-life. So don't be in a hurry. Start small and go slow. So whenever you're switching from other opioids, suppose you're switching from morphine to methadone, what they say is calculate what is the oral morphine equivalent dose. That means how much he needs 24 hours of morphine. Suppose a patient needs 5 milligram Q4H. So his oral dose, oral OME, oral morphine equivalent dose is 5 into 6. 5, 60, 30. So they say if the dose OME requirement is less than 60, just like I said, start like this. Just start with very small dose. When the OME is small, less than 60. If the OME, that means oral morphine requirement per day, is between 60 to 200, go by 10:1 conversion. That means 10 milligram of OME is equal to 1 milligram oral methadone. Suppose a patient OME, that oral morphine requirement is 60 milligram. That means he needs 10 milligram Q4H. That the conversion will be 6 milligram of methadone. And you can divide methadone into 2 or 3 divided doses. You can make it BD or 3 times a day. Either way, it is fine. BD or 3 times a day. If the OME dose requirement of methadone is more than 200, 20:1 conversion. This is the very simple guideline. I'll leave the slide with you. Suppose any point of time you want to refer back to this, you can, it's easy to remember. So less than 60, more than 60 to 200, 200 and above. Less than 60, start small. Above 60, 10:1 conversion. More than 200, 20:1 conversion. This is a very simple conversion which we have to be familiar with. Should not increase before 5 to 7 days. Should not increase, avoid increasing more than 5 milligram per day. Like, don't rapidly increase. And can be increased by 10 milligram per day after 5 to 7 days. Same patient, suppose you switch over to methadone for this patient. You found this is a complex neuropathic pain condition, but he lives alone in a district, he's alcoholic and irregular follow-up. What do you see the high risk here? By looking at this lifestyle of his, what is the high risk here? Do you recognize any risk factor? He lives alone, irregular follow-up, also is alcoholic. Alcohol is a risk factor because methadone and alcohol has a additive effect, and it can cause problem and also problem with the metabolism. Hepatic toxicity can be a problem, yes. More than that, living alone, an irregular lifestyle, yes. If he goes into any of the problems like too drowsy, we won't know what is happening to him. Drug abuse won't be okay. It can be a remote risk because he has this very wild lifestyle. But more important is that he's so sick, and you put him on methadone and send him away to a village, remote village, where you can't even follow up. I will not be very comfortable. I'll never start methadone on a patient where I don't have a good follow-up with the patient. A responsible family member is not around with the patient. I will not be comfortable starting methadone. It can cause more damage than doing good. So remember that patient selection, when you say it, you should have a responsible patient and the family to do it. So potentially inappropriate candidate for methadone from that point of view. If you see patient who lives alone, poor cognitive function, and without a responsible caregiver, practitioner on transfer. Suppose a local, if you're not very sure who is going to support the patient nearby, maybe avoid non-adherence to treatment. And suppose there is a risk factor like clinical instability or multiple transition of care, moving from one hospital to another hospital, where that particular hospital may not have any idea of methadone, better not to start on methadone. And when there is history of QT prolongation, of course, poor prognosis, less than 5 to 7 days at the end of life care, no point starting methadone. I would rather start him on injectable morphine or obstructive sleep apnea, because it is known to pronounce sleep apnea, many of these patients. So you have to be careful. Good question. So are you going to start methadone only in hospital? I would say yes and no. Yes, if you don't have a proper system in community to follow up, I will start the patient on methadone, stabilize him in the hospital, and then send him home with the proper training of the caregiver. That should be the protocol. In my hospital where I work, I also have in City of Hyderabad a proper home care follow-up system. So if I start a patient on methadone, I'll call up the home care team, hand over the patient to the home care nurse, and give the proper instruction. Please follow up on this patient for next at least 1 week and tell me how he's doing. If you have that kind of follow-up system, yes, you can send the patient home. Otherwise, ideally, admit the patient, stabilize the patient 5 to 7 days, make sure you know what the dose requirement is, and the family is trained enough or the patient is trained enough. Yes, you can send the patient home after that. So these are safe practice when you're using methadone. So yes, a lot of drug interaction when you use antibiotics and methadone, QT prolongation. But remember, these things will be, that it's not an absolute contraindication. These are, you have to be mindful. So take the baseline ECG and they say repeat ECG after 2 weeks and then 1 month, and then you can check how he is doing. So if you're very concerned about use of antibiotic and use of methadone together, but in hospice care, I will not go for any of these things. I'll just look at my goal of care at that point of time is comfort. So I'll not be really chasing blood electrolyte or ECG for such patients. And when they go home, please remember always again give the instruction safe storage, because look at this liquid methadone. It looks like nice orange syrup. And I had an incident where one of my driver patient, he kept cup syrup in the fridge, and the child thought it was orange juice and came and drank the thing from the fridge, the cup syrup. So imagine if you keep a methadone syrup like this in a fridge and accidentally someone consumes it, drinks it, it can be disastrous. So you have to keep the methadone in cool storage. Don't have to put in the fridge, cool place, but under safe lock, away from kids, away from pets. So keep it safely. That instruction should be given to the patient. I'll just stop here and I'll take questions. Yes, very good, excellent question. How will you manage breakthrough? Normally, what we say is that even when the patient is on methadone, you can add morphine as a breakthrough for backup. Some centers, they use methadone as a breakthrough pain, but I will not, for as a beginner, I will not recommend that, because then suppose the family takes breakthrough, just like morphine too many times, it can be disastrous. Rather, still stick to morphine for breakthrough pain. So the take-home message is methadone has multiple sites of action. And because of that nature of methadone, you can use methadone for very complex neuropathic pain conditions. But normally we don't use methadone as a first line, generally, unless you're very confident about using it. But two things we must worry about is it's QT prolongation, multiple drug interaction, and prolonged half-life. These three things you must remember. And but it's excellent for patients with renal failure, very safe. You can use for renal failure patients. The dose titration is start small, go slow. Less than 60, maybe just start with 2 to 2.5 milligram BD dose. 60 to 200, 1/10 conversion of mean equivalent dose of morphine, 24 hours dosage. 100 to 200, more than 200, 1:20 conversion. Follow up on the patient at least for 5 to 7 days. Don't start methadone on a patient where you don't have a responsible patient and the caregiver, and they have very poor understanding. They don't understand. I don't think we should be using morphine. Methadone responds to naloxone. So just like morphine, if there's accidental consumption of too much of methadone, admit the patient, maintain the airway, oxygenation, circulation, use naloxone. Give in bolus doses, and then maybe if the patient is prolonged action, you may have to use infusion naloxone. So NMDA receptor action, I don't know whether you had a session around pain. When you have chronic pain, our central nervous system undergoes a lot of changes. A central nervous system in the periphery as well as in the center, we call it as neuronal plasticity. So there's a lot of nerve changes happens and they get highly sensitized. And we call it a central sensitization. The nerves become like this wound up. And when you any further stimulation, they release a lot of chemicals. And that leads to exaggerated pain in chronic pain. So in chronic pain, because of this nerves getting super excited, so even a small stimuli, they release chemical and more pain they experience. This is known as central sensitization. And these things happen at a spinal cord level, and the receptor responsible is NMDA receptor, non-N-methyl D-aspartate receptors. And methadone works as a NMDA receptor antagonist, which means that it prevents this hypersensitivity of the neurons at the spinal cord level. So when chronic pain, when the patient is in a heightened state of pain, it calms down the nerves working at spinal cord level. And that's how it works. Same mechanism, they say, okay, the question of opioid tolerance, especially with morphine, it's quite a known fact that they develop tolerance. That means, what do you mean by tolerance? Tolerance means for the same analgesic effect, you need much higher dose of drug. So for the same therapeutic benefit. For the same therapeutic benefit, when you keep on increasing the dose of medicine, for example, hypertensive medicines you've seen. So after prolonged use, you need higher dose of antihypertensive medicine to produce the same control of blood pressure. Same way here in morphine, for the same pain control, sometimes we will not we get pain relief, and then you need keep on increasing dose of morphine. And sometimes in the process, a lot of undesirable side effect happen. Then you know probably the patient is developing tolerance. It's a very clinical judgment, comes with experience. And that point of time, you think maybe it's a time I should rotate to opioid, another switch out to another opioid. And when you switch out to methadone, it becomes very clean. Much smaller doses of methadone you'll need, and you'll come out of all those unpleasant side effects like constipation, nausea, vomiting. Sometimes they get confused because of morphine. Suddenly patient becomes very calm, and the patient becomes very comfortable with much smaller dose of methadone. So this is what we call it as opioid rotation. And morphine does not help with central sensitization. Morphine has action on opioid receptors. It does not have any clinical significant action on NMDA receptor action. So no, it may not be a good idea to have. Another drug which we use for central sensitization is ketamine, other than methadone.
Ma'am, there was a question. Can we use NSAIDs with methadone?
There is no absolute contraindication for use of NSAID with methadone if there's element of inflammation. Anyway, whenever I'm using NSAID, I will not use prolonged use of NSAIDs. I'll use for a period and stop it. Because if there's element of inflammation to reduce inflammation, I'll use for 5 days or 4 days and then stop it. Because anyway, it's not long term. And most of our patients are already barely compromised with their kidney function. So we had to be more guarded with our patients. Any other question which Arjun, I missed, which we need to?
Which drug is comparable to methadone? Dr. Rahul, can you explain the question?
Good evening, ma'am. Good evening, sir. Like, we have to be so careful about using methadone, especially when given for home care. Do we have any drug which is more safer to give on home care basis, which may have equal efficacy as to methadone or maybe a little less, apart from morphine?
So my purpose of scaring you all away with methadone is just so that you're cautious. But if you know how to use it confidently, we can use methadone even in home care setting so that we have a proper follow-up system. That I would like to start with that. But having said that, I will use methadone only as a second line. I'll always prefer morphine to start with. All my unstable patients, I will not even try fentanyl. For all unstable and uncontrolled pain, I'll give a fair trial of morphine first as a first line, and then I'll see whether I need to switch over to any other opioid. So I'll play around with morphine only remember that in a clinical analgesia point of view, methadone, morphine, they're all very similar. Unless there's a complex other pain conditions associated with that. Sorry. So yes, Rahul.
Ma'am, where I practice, I get patients who are not very educated. You can understand, na? So explaining to them and expecting something out of them to report back when the complications occur and all is a very difficult task. So that was the reason.
Better not to start, because I have seen instances in my own program. In spite of all the monitoring we do, patients, they get used to morphine 4-hourly, because all the time we say morphine 4-hourly, morphine 4-hourly. So they get tuned to this morphine 4-hourly, and then we switch over to methadone. We had a couple of instances. They're so pain medicine means 4-hourly. They took methadone 4-hourly. Fortunately, we came to know about it, and then we had to stop them. So we had to be, yes, if you don't have that mechanism, better not play around unless, and not many patients you'll find who need this kind of complex pain conditions. So be selective about the patients you're going to use methadone. That's what I would say. So routinely, just like that, we are not distributing methadone. We'll very selective patients we'll choose, and once we choose, then give that extra care. Arjun, what is your experience in your center?
Ma'am, regarding using home care also, we initially started using in inpatient unit only. Only after we practiced for some time, and around 2 years we were confident enough. Then we started using in home care. Still, only for lower doses we prefer at home care. And if the patient is requiring higher dose, we will definitely bring them to IPC.
Absolutely. So remember that what Arjun says is two things. One is patient's point of view, whether they are capable of following your instruction. Second is our own competency and confidence. And so choosing patient wisely, which patient would require methadone, is very important. When you see a complex pain condition, better bring the patient back to your IP, understand why this patient is having such complex pain condition, what are the pathophysiology involved, and then choose analgesics wisely is something we would recommend. Yeah, absolutely. And tramadol, yes, it works as a neuropathic pain, works in neuropathic because of it. There also it inhibits reuptake of TCA-like action, 5-HT noradrenaline. But remember, tramadol is a weak opioid. So when somebody is having severe pain, tramadol may not be enough. So
just adding one point, it is also important that as you said, the patient selection is important, because many a times when they go to a nearby hospital or some other medical professional, they won't recognize methadone as an opioid. We have seen many times that they fail to. They would be knowing about morphine, but methadone very few people know. So issues has happened. So the caregiver should be should be aware enough to tell them that the patient is taking a step 3 opioid.
Absolutely. So methadone had like so many interactions. Why don't we use other adjuvant medications? I would say for all of you, especially if you're just beginning, please first get familiar with morphine. Learn to titrate morphine. Learn to effectively manage the use of morphine, its side effect. Get very confident with morphine, along with adjuvant medications. As a beginner, I would say, like, it took us many years to confident about switching over methadone, morphine, fentanyl, like that. It takes time. So first, to get confident about use of morphine, its titration, side effect, toxic effect, and use of adjuvant medications like tricyclic antidepressants or gabapentin or valproate, like that. Get familiar with that system. And then once you're there, okay, I'm set, then think about adding methadone. That's a recommendation, because everything together can be more confusing. So let's go slow on that. And procuring methadone, it's the same license which you apply for morphine. You have to add methadone in that request letter, and the same way how you procure morphine, same way methadone is procured.
There's a question for patients with fibromyalgia and CFS, which drug can we use?
First of all, what is the second condition? Chronic.
CFS. Dr. Sheila, can you please explain?
CFS syndrome. Chronic fatigue syndrome. Okay. Both, what my understanding about chronic fatigue syndrome and fibromyalgia syndrome, the treatment is never opioid. I don't think we should be easily starting a patient on opioid. There, the pathophysiology is quite different, and it's a lot to do with the general consensus is that more about lifestyle modification, antidepressant medications, and use of gabapentin. That kind of drugs are more recommended than starting any opioid for such patients, and lot of physical rehab and rehab therapy like that. I know it's not easy to manage patients with irritable bowel syndrome, chronic fibromyalgia, or chronic fatigue syndrome, but I will be very wary of starting opioids so easily in such patients. That should not be the first line. Even for chronic back pain, chronic neck pain, unless it's so debilitating and they're almost bedbound, I will use that other non-pharmacological approach and other aspects. If you look at the consensus, opioid comes quite down in the list of things in these circumstances.
With patients with severe chronic pain, can methadone be a first choice instead of morphine? Must morphine be used before switching?
Yes. If you're confident, we can straight away start with methadone, provided you know how to track what's happening to the patient. You can. In many centers, they use easily as a first line. I think we are already.
The comment was probably it is the only opioid useful in neuropathic pain, tramadol also.
Yes. Yeah.
Ma'am, I just ask, are there any medical legal issues regarding use of methadone? Because sometimes we might not do an ECG in end of life. And if obviously end of life, the patient will not live for long. But then if we use methadone, can there be any medical legal issues regarding it?
It's like it's finding needle in a haystack, I would say. It's because often when people die in end of life cases situation, when somebody's forget about methadone, even when they're on morphine, the entire blame goes to morphine for some reason. Oh, patient mar gaya, patient deteriorated because patient was on morphine. Every blame is on morphine. As you practice, you'll realize we face this every day. Everything they attribute to morphine. What we don't realize is patient in end-of-life care is often dying because of multi-system failure. The different systems start shutting down, and renal output gets affected, liver, heart, brain, everything slows down and they shut down and they die, multi-system involvement. So it's multifactorial reasons why the patient dies. And often our medications may attribute to the cause of death, but it's not the primary reason why the patient is dying. But for some reason, we are so scared of opioid that every ill in the society, we say it's because of morphine. The same thing applies to methadone. So my response to you would be no. If you know, understand how to use it in a judicious way, and you document it well as to what is your goal of care. When you mention your goal of care and you use analgesics with that intention, you're safe. Because the court of law, they look at the goal of care and your intent of treatment. If your patient had intractable pain in end-of-life care and your intent was to treat pain and you use methadone and you document it, you're safe.
One final question. Can methadone be used safely in children? Is it same as adults?
In fact, we have done studies and we have found that it is as effective as in adults methadone. So there is quite a number of studies about use of methadone even in children. Yes, we can use it. And patches and morphine should be withdrawn. Once you start methadone, you can't have two opioids going together. Two opioids of the same class you can't continue to use. You should stop and maybe just leave morphine for breakthrough pain.
Thank you, ma'am. That was a very wonderful session, and we had a very good interaction with the team. Thank you for inputs. And we are sure the teams might be having more questions. Please send it to our WhatsApp group, or please let us know. We'll get back to you with the answers. Thank you, ma'am. Shall we wind up the session, ma'am?
Yes.
Thank you.
Thank you. Thank you for the wonderful session. Thank you, Dr. Ajib, for facilitating. Thank you all for participating actively. Thank you. Let's see you in the next session. Bye.
Thank you all. Have a good day.